Good morning, everybody. Thank you very much for joining us this morning. We have a very interesting session on healthcare in danger, one of the most important challenges in the humanitarian world today. My name is Isabelle Daou. I'm from the Canadian Red Cross, and I'm joined today by a wonderful panel of experts. We are missing one expert from MSF, but we hope she'll be joining us any minute now to join this conversation and bring her operational perspective. So as I said, our panel today will address the issue of healthcare in danger, which is about violence that is directed towards healthcare personnel, clinics, patients, hospitals, ambulances, and is one of the greatest challenges today. These sorts of attacks, unfortunately, don't only happen in armed conflict. They also happen during natural disasters. They also happen in Pakistan, as we've seen attacks against polio vaccination workers being attacked in those regions. Healthcare in danger is very important for us here in Canada, as Canada is known to deploy a number of healthcare personnel abroad, and we want to make sure that they remain safe. It's also important because in 2015, governments of the world will gather in Geneva at the International Conference of the Red Cross and the Red Crescent to address this issue, together with the 189 national societies that form the Red Cross Red Crescent movement, as well as the ICRC and the Federation. So this will be a very important issue on the humanitarian agenda next year, and we also think that it will be featured at the World Humanitarian Summit the following year in 2016 in Istanbul. So we wanted to change up the format of the panel and be quite informal and proceed along a question and answer format, and the panelists have agreed to play along with me in that format. And what I'll do is I'll ask a first round of questions to each of the panelists. They'll be able to respond, but then I'll immediately open it up to you, the audience, so you can jump in with your own questions, and then we'll go for a second round of questions and open it up again to the audience for further discussion. So, Robert Young, you're sitting to my left here. I'm going to start with you. You've got extensive experience in the field. You've worked for the ICRC for, I would say, at least 15 years. You've worked in Ethiopia and Colombia, in Abidjan, West Africa, and Budapest. But you were also working in New York with the International Committee of the Red Cross, attached to or representing the ICRC at the UN. So you've got an interesting mix of operational and legal diplomatic experience. Can you tell us a little bit more about the genesis of healthcare in danger and how the ICRC came about being interested and concerned about this issue and what your organization is doing about it?
Sure, Isabel. The ICRC launched this project, Healthcare in Danger, because of our own field experience, our own field observations, really at the start of this century. And what we observed was our own personnel were increasingly at risk, as well as our partners in Red Cross, Red Crescent, national societies around the world. But also, importantly, we observed that colleagues working in healthcare, national colleagues, whether working for NGOs or for public institutions, were increasingly at risk, and so were their patients. What we documented were more and more attacks, more and more threats, more and more intimidation, all of which had a very negative effect on the access of people to healthcare, especially people already vulnerable because of conflict. So we launched this project not only as an ICRC project, not only as a Red Cross, Red Crescent project, but something that goes beyond that, and that's why we're very happy to be talking about it today.
Great. Can you tell us a little bit more about, I know that you've collected data in a number of countries to document this, and you've noticed that there's a pattern of attack, but can you elaborate a little bit on how the ICRC has put in place a process to address this challenge?
Yeah, the project, which was originally intended to run from 2011, when the International Red Cross Red Crescent Conference, as you mentioned, basically asked us to do this, has a number of elements, and one is, of course, gathering more data. We knew there was a problem. We've started documenting ourselves, but we've also tried to join up with others who are researchers and NGOs and think tanks who are collecting data so that there's more of an evidence base for that. So there's a track of research, there's a track of expert workshops that have taken place around the world. One here in Ottawa that, of course, the Canadian Red Cross helped organize with the ICRC on the physical protection of physical structures of healthcare around the world. That workshop was followed up, for example, with another workshop in Pretoria jointly hosted with the South African government. So these series of expert workshops are all aimed at trying to come up with practical measures that will make a difference on the ground. This is not an exercise in elaborating new legal rules. The whole point of departure is that the legal rules are very clear. There's really nothing more basic in humanitarian law than protecting wounded people, protecting healthcare workers, protecting ambulances and hospitals. So it's to get better practical measures to reduce the exposure of people to the violations. And this is proceeding over a number of years.
Great, thank you. Niels Mork, you flew from Oslo, Norway just a few days ago, so thank you very much for joining us here in Ottawa for this panel and this conference. You have extensive experience with MSF. You've also worked in the field. You come from a management / communication advocacy background. I'd be interested in your perspective in terms of MSF, because MSF has been equally interested in this issue. Can you tell us a bit more about your organization's engagement on healthcare in danger?
Yeah, sure, Isabel. Thank you for having me all the way from Norway. Well, first of all, I think it's important to go back and see why this is an important issue. And it's not, from our perspective, because doctors are somehow special people that should be spared. And it's not because humanitarians are special people. I mean, we are talking of attacks on civilians as well. Rather, what we see is that when we are faced with attacks in our field missions, then we are forced to withdraw or reduce our staffing or in some cases entirely exit the country like we did in Somalia. So in other words, when these attacks happen, we lose access to our patients. That's what it's about. It's about patients, ultimately. And that forces you to review the question in the other sense. What can MSF do better in terms of staying operational and keeping access? How can we mitigate risk better, understand risk better? So in doing this, we took the opportunity to go back and review and analyze again what we know about the attacks we're faced with in terms of who attacks us, with what intentions do they attack us, what sort of typology of attacks do we have, and how do they influence our response and the consequences. We're still working on this, and we are planning to release all this work in a report on the 31st of March, the Medical Care Under Fire report. But I can tell you right now, it's been a work that's in many cases been full of surprises, both in terms of who attacks. I mean, we all know the global narrative of instrumentalization of aid and therefore politicized attacks in return. And there is some truth to that. But very often, when you go down to the field realities, you see that attacks come from patients, right? And their families who may be attacking or threatening to attack because they are not happy with the level of care, or because they live in societies where if you have a grievance, there's no one to go to. You can't sue very often. You can't go to the police. You can't go to a complaints mechanism. So you grab your weapons and you go and try and sort this problem out. It's also been in some cases surprising to see that staff are an issue as well. I mean, we tend to think of ourselves as being somehow exclusive or separate from the societies in which we work. But of course, for MSF's experience, we have 90% national staff. And in some contexts where we work, we are one of the biggest employers, often the biggest medical actor. So we're very obviously part of these societies. We have a very strong relationship with these societies. And finally, we've tried to look at the basic question, which is medical care under fire? Meaning, are we faced with more attacks now than before? And we've looked at all the data that we have access to, and this is going to be included in this report. But one of the key conclusions we have very early on is that a global statistical lens isn't necessarily a very good one to try and understand the issue. I mean, violence is a human thing. It's not a mathematical thing. And if you look at the global picture, you very often lose sight of what is happening right now in that mission with that guy with the gun. Right? Why is he attacking? What are the intentions that he has? And rarely you will hear people say it's because of instrumentalization of aid and blah, blah. It's very often much more complex, much more human, and we're trying to approach it in a human and objective fashion.
I want to drill down on that a little bit. So you're saying that perhaps the global data is interesting to show patterns, but what's more interesting is to focus on the context at stake and to have a better understanding of the attacks in order to have a tailored response. Is that?
Yeah, absolutely. And clearly there are some patterns can be drawn globally. I'm not saying that we shouldn't have data, but I think it's easy to become enamored with our data. And, you know, it's very easy to look at these graphs and they present you with somehow a useful map of reality, but it is just a map. And the map and the actual geography of the world is very different.
Thank you for that. Adrian Di Giovanni, you have extensive experience as a lawyer. You've done your Master's of Law at New York University. You have been working for the International Development Research Center, IDRC, since 2011. I think it would be useful for the audience if you could provide us with a bit of the legal framework around this issue, but also some of the ethical questions that this issue poses.
Sure, happy to. And I very much come at these issues as a non-humanitarian, and I spend a lot of time on the development side. And a lot of what we look at is how do you get better respect for laws in situations where it's most difficult. And I should say in context of non-conflict, sort of the everyday, that's already a huge challenge. And so when Robert and I were kind of throwing around ideas, what would be an interesting panel, this is one that really came up because the laws are so clear. And so I'm going to spend a minute talking a bit about the international legal framework. And so then there's a question, if the laws are clear, how do you go from a situation where they are clear and unenforced to better enforced? And so it's a real chestnut of a problem. And our goal today wasn't so much to try to come to the answers, but just to give a better sense of how these issues map up to existing legal obligations, and then if the law isn't being respected, what ethical problems are raised. And so really, to take a step back, what you're dealing with are the basic laws of war, what they call international humanitarian law. And these are laws that go back 150 years to the 19th century, and really were developed to help try to make war and the battle more humane. So you're mitigating the effects of conflict. And there's one side about, you know, how much force do you use in battle, and really looking at armed forces. But then it's also, the intention was very clearly to distinguish between those party to the conflict, the armed forces, and civilians. And on top of that, and this is, for some of you, this might seem overly basic, but we thought we'd start basic. On top of that, this distinction between civilians, combatants, between healthcare workers and patients. And so from the beginning, there's always been clear international legal obligations. And for those of you who think, oh, international law, it's not a real thing, these are the ones that have always been respected throughout history, or at least the modern history of warfare. And so dealing with how you treat patients, giving access to healthcare, allowing what they call respect for existing healthcare workers, protecting healthcare workers also, and also patients, and ensuring access to medical care, not discriminating who you give treatment to. So when you see an injured person on the battlefield, it doesn't matter which side of the conflict, or allowing your opponents essentially to gain access to their own wounded. I won't go much more deeper in the detail. If anyone wants more, I have Geneva Convention 1 here. That's where a lot of those show up. And I think the one thing, though, to focus on, where it becomes really interesting for lawyers, and these are the sexy international law issues, is that the nature of conflict has changed. So we're not dealing with the image of the 19th century where you have a battlefield and soldiers on two sides and coming to clash. Increasingly, conflict, as we all know, takes place potentially in urban settings. Who's a soldier, who's an armed group? Those distinctions are very much blurred. And even as the World Bank's 2011 World Development Report said on conflict and development, the majority of deaths are now suffered from forms of conflict and violence do not fit neatly either into war or peace or criminal violence or political violence category. So everything's being blurred, and we could have done a whole panel on what does that mean for international law. We were kind of pushed away from that, but those are questions when people, for example, talking about drones, are they good to be used or not? These are some of the issues, because which actually framework of law applies is very muddied. And on top of that, and this is a point Nigel Fisher made yesterday, there seems to be compliance is slipping away from basic obligations, and you see it on human rights, you see it on discussions around torture, all the discussions around Guantanamo Bay over the last decade or so. That was about, if you go back to the heart of it, basic international humanitarian law questions. So.
Bienvenue, Joséphine.
So part of what we've been doing is also extending the conversation while Josephine was able to come. But what I've tried to do just now then is show how the situation is shifting. A lot of the lines are muddied, crossing. But with respect to healthcare workers, to patients, nothing's changed. Those have always been clear obligations. They continue to be. Doesn't matter which law you want to argue on a more academic sense, which one applies. Patients, healthcare workers are off bounds, yet they continue to be targeted, or they're being targeted more if you listen to some of the findings coming out of ICRC and MSF. And so what this does then is, if your starting point is the basic laws aren't being followed, the basic question, what do you then do? And as a first step, what it does is it raises many dilemmas, and they're largely ethical. They're not purely legal, and you can only go so far in giving sort of guidance and advice, is that you have a series of dilemmas that weren't necessarily there before, or they heighten existing ethical dilemmas. And some of them could be, for example, do you actually provide health care or not if you're putting yourself in too much danger? And I think that was the Somali example that you mentioned. Do you ramp up security around healthcare facilities, which could make it, make more secure both the healthcare workers and patients, but you might impede access. You might also become a target more by more clearly being more visible. And generally being visible as healthcare workers, again, that's part of the basic obligations. In fact, if you're providing healthcare, you clearly put an emblem up, whether it's the Red Cross, Crescent, but now that actually becomes a target. So do you then decide not to advertise yourself, which might make yourself less accessible? Or then you're in a sense going along with the lack of respect for the law, because you're in a sense opting out of the existing protections or framework by saying, well, I'd rather provide health care sort of informally or on the QT, as they say. That's just an initial sort of painting. Very hard. Dilemmas don't have clear answers, and so that's just to give a flavor. I think we're going to continue talking, so I'll leave it there.
Great. Thank you, Adrian. I want to take this moment to welcome Joséphine Sishibanji. Bienvenue, Joséphine. I will be asking Joséphine some questions in French, so if you...
Welcome.
Some. And while you do that, Adrian, I think what you're touching on is that the law is clear, it's there, nobody's calling for updates or changes to that law. It's fleshed out in the Geneva Conventions and in various human rights treaties in terms of the protections afforded to civilians, but also to humanitarian and health workers, and then medical mission more generally. What you're pointing to is when there's a breakdown in the law, what does that force health workers to do? It forces them to look at different solutions or alternatives that might compromise the quality of the care or the type of care that they're able to provide. So that raises an important dilemma, I think, for workers on the ground. Joséphine, je vais passer en français.
Joséphine, welcome. Thank you. You're a nurse with more than 20 years experience. You've worked for Médecins Sans Frontières for some 13 years throughout Africa. I was looking at your CV in Mali, in Niger, in Mauritania, in Ivory Coast, Zimbabwe, etc. So you have a considerable experience of work in humanitarian context of a rather fiery nature. we've dealt with the issues of healthcare in danger, but could you speak of your personal experience? So what did you actually experience in the field? What has been your experience and the experience of your colleagues in the field? Can you tell us? Well, hello, everyone, and I'm sorry I was late. We were lost. We looked for the number of the building, and we finally found it. As Isabelle has just said, I have worked in countries at war. It is quite a challenge to work in these countries because the populations need humanitarians in these difficult moments. From my experience, I would encourage everyone in offering support because it is necessary, but it is sometimes difficult. The experience I will relate is my latest experience in West African Republic. We had set up, and the both opponents were firing against each other. So patients are there, and so some people have already been fired upon and have bullets embedded in their flesh, and we also have to protect ourselves, so it is quite the dilemma. But good cooperation among humanitarians helped us save lives, because with the various humanitarians and MSF, we gave each other information. We told each other whether we could go on caring and how can we protect each other while fighting is still going on. So we managed to save many human lives, but the population suffered because we had to leave some patients behind because we had to leave the clinic. And that's the story, Isabelle. So the situation is quite delicate. Josephine, you also told me that one of the solutions you had found in the field was to use one of the residences of the MSF staff. Could you tell us what constraints that entails? Well, in that situation, sometimes we couldn't go to the clinic itself because there was fighting going on everywhere. So as a team, we decided to have one room where we could at least supply first aid care, and then with the African Red Cross, we could help. But many hospitals had shut their doors, and we had perfusions, we had band-aids to stop the hemorrhaging, but ICRC took our patients and brought them to some hospitals at a lot of risk. We know that this was difficult because there were not enough doctors in the hospitals. There was unsterilized equipment, but we still managed to save some lives. Thank you, Josephine.
This is that the law is clear, yet it's being violated all the time. This forces health workers to come up with alternative solutions, but these alternative solutions also create compromises and ethical dilemmas. So it's a very complex issue. I'd like to see if there are questions from the audience now or from the social media before we go on to the second round of questions. Yes.
Oui, Pierre Micheletti, je suis
I'm Jean Micheletti. I'm a teacher at the Grenoble and University. I'd like to make a general comment on this general theme and explain my point of view. The general comment is you can't globalize all situations that are risky. There are trend evolutions. We can discuss figures to find out whether the danger is increasing or not, and that was the comment by the colleague from MSF. But if danger is increasing or not, what we do realize is that immunity for humanitarians is a given, but we are no longer being protected as doctors or nurses, etc. So each situation is a particular case. I'll give you 2 or 3 examples of humanitarian situations where healthcare workers were taken as targets. You mentioned the Pakistan polio vaccine operators, but they had played a role in the finding of bin Laden. That was a part of the context. In Haiti and the MSF teams, you can understand the violence against the healthcare workers only if you think of the cholera epidemic, which added to the complexity, and also the way a lot of humanitarians forgot about traditional medicine in the context and creating resentment against the humanitarians. In the case of Ebola, that's another issue. The funerary rites have been set aside, and in the case where the Syrian medical community was targeted, you can only understand the situation in as much as you take into account the history, and when you understand the role that the Syrian order of doctors played towards the Assad group. They were historically opposed to the Assad regime, so a global analysis with figures, yes, but you still have to analyze locally and from a historical point of view.
Actually, a nice segue to our second round of questions, because there are solutions to this problem, but the solutions have to be tailor-made to each context with a sound understanding of the security threats that come towards the health professional. I think this is a critical point, and thank you very much for bringing it forward. I also want to say that this is not a new issue. I know the ICRC has put this on the international humanitarian agenda in 2011, but I think several of our local healthcare provider colleagues have been facing these issues for decades now and have come up with coping mechanisms that are tailor-made to their situation. Something that hasn't come up yet, I think, from the data is that 90% of attacks are actually against local healthcare providers. So it's not so much about ICRC or MSF or Médecins du Monde or other organizations being targeted. The data is showing us that it's local health providers that are bearing the brunt of these attacks. So let's shift a little bit towards solutions if we can. And Robert, you talked about the process that the ICRC has launched in terms of a series of workshops to come up with specific solutions on clear thematic issues. Can you tell us a little bit more about the tools that are being developed now to help healthcare workers cope with this problem?
Certainly, yeah. No, I couldn't agree more with the point that's been made about the particular context and the analysis that's needed there, and that's certainly true. That being said, these cross-cutting patterns are presenting themselves, and that's what drove the ICRC to launch this project. We're also coming up, as I said, the whole project is very focused on practical recommendations and tools that will be used for healthcare workers on the ground. Just mentioning quickly the statistics, I want to mention there is also, it's very true what you said, 90% of the attacks and threats in the data we've collected, for example, over 2012, 2013, about 1,800 incidents in 23 countries. Now, I'll bracket that and say that, of course, that's not a comprehensive data set. That's just what we've been able to collect, and we know that there's underreporting of the threats and attacks. Particularly, if we take one example, attacks or threats of a sexual nature will be underreported, we can expect, both by healthcare workers and by their patients who are vulnerable. So, but nonetheless, the trends that we see there suggest that 90% of the attacks are on local healthcare workers, but many of those, and that's why I think it's important for this group, many of those will be working for partner organizations. They may be working for ICRC, they may be working for the Syrian Arab Red Crescent, but they may be working for local NGOs, they may be working for the local health authority, and they are very courageously continuing to work during moments of crisis. But in a sense, the further you get from an international organization, the data shows, the more at risk you are. And that's why the solutions that are being proposed are meant to be tools in the hands of those people. So what are some of those? The first publication that we produced after expert consultations was a booklet, now available online, on the rights and responsibilities of healthcare workers and healthcare professionals, and that sets out some strategies and mechanisms that they may adopt. It was produced as a book, now it's something that's available online. There are a major set of recommendations that will be coming out this year that range from managing human resources, that range from the physical protection, how to balance access and the protection of staff and facilities. And so there are a number of tools in the pipeline that will be available. If you Google healthcare in danger, you'll fall right on the ICRC website. And I will mention, if you allow me here, that there is also a platform that you can get access to simply by asking. And if you speak to me or Isabel or Sharonya Sekar from the Canadian Red Cross, who's sitting here in the front row and is one of the experts in Canada, then we can make sure you're hooked into that platform where you find data from a whole bunch of organizations. We're very much in this next phase trying to compile from around the world best practices and use that platform to share for all of us involved in this and provide greater support and solidarity with colleagues on the ground.
That's great. I think the sharing, Rob, that you mentioned is very important because while each situation is different, I think there are patterns that we can learn from. And I think, for example, the Lebanese Red Cross or the Palestinian Red Crescent has faced a lot of challenges in the past decades and has come up with solutions that could be shared, for example, with the Syrian Arab Red Crescent. And so I think more of this sharing amongst the humanitarian sector is critical so that we can continue to build on these practical solutions. Niels, I want to talk about advocacy a little bit because I think that in parallel to field-based solutions that can be adopted on the ground, I also feel the need to start stigmatizing these attacks. When is it that we started to consider these attacks as normal or acceptable risk? I'm quite shocked that the norm, the sacrosanct norm of protecting healthcare personnel seems to be eroding on a daily basis. So can you tell us a bit more from an MSF perspective, what kind of advocacy efforts you're doing to ramp up awareness of this issue?
Yes, well, I mean, this is something we've advocated and communicated and spoken out about for many, many, many years, obviously. And I think the first thing I would say is that, again, these problems, these attacks and insecurity we face is highly contextualized. It's very different in Pakistan following a CIA-sponsored vaccination undercover operation. That's a very contextual issue. And you can have your advocacy push or your condemnation then via the US, and you clearly have some work to do in Pakistan, although I don't know how to rebuild that trust, to be honest. But in other cases, it's a very different issue. And I would hesitate to say that our advocacy efforts should be seen as something that happens in our home societies. We have a huge advocacy work to do in the countries in which we work. And again, this is not a one-size-fits-all issue. It's going to be very different in how you approach the very messy conflict that is happening in Syria and Iraq. That is going to require a very, very contextualized approach, which will be completely different from what you do in South Sudan. And there might be some commonalities in terms of principles in IHL, etc. But very often you really have to dig in and accept that you might not know the full picture here, and you really have to do your research. And that's my main point about my skepticism towards the global data. Not because I don't think global data could exist, but because I'm not sure global data will get us anywhere.
So Adrian, I'm back to you in terms of the law. The law is clear, yet it's being flaunted, and we're not calling for a new normative framework. So what can be done to increase respect for the law and to also address some of the ethical dilemmas that you've posed?
Yeah. I mean, that's in a sense the question that haunts me every day when I show up to work. How can you get better respect for the law? And one comment I always get from people is, you lawyers, you think you can solve all the problems with the law, and I think this is a clear case where there's only so much you can do. But what I'd start with is some of the basic ideas we work with, or even basic theories of change. One is just about promoting better awareness about existing laws, and that might seem overly basic, but we've seen it whether it's dealing with rural communities and better sensitizing people around rights around land, or you're dealing with urban populations in slums, dealing with sanitation. Even just that basic awareness among communities of existing laws, obligations or responsibilities of different parties, that already can have a powerful effect. Some of it's because communities, they live together, and whether it's the local decision maker, whether it's what you'd call belligerents under the legal framework, they all come from the same communities, and oftentimes, or they're all answerable to each other in one way. And so that's in a sort of very local level. There's also at an international level. These are such sacrosanct obligations. Few countries will overtly come out and say, no, we don't care about it. Even if it's lip service, at least there you're setting some ground markers. And so at least having countries reaffirm their commitments on an ongoing basis has an important role. My own views is I'm not one to say, well, here's the international obligation, therefore, and you arrive the international community in all cases and tell countries or parties to conflict you have to follow. The solutions oftentimes, the interesting ones, are actually through national legislation and ensuring that there's good frameworks there, whether in times of peace or in times of war, and so that it isn't this false distinction between humanitarian situations or peacetime. It's really about building up a culture of basic respect for laws, rights in general. That, in a sense, is to restate some of the problems, though, because we're dealing in contexts where often in the lead up to the conflicts, it was a breakdown in the rule of law, so you're back to the starting point. So that's just in a general sort of, how do you do it? It's not clear, and sometimes it's actually a very political, diplomatic route, which was talked about yesterday in some of the sessions. On the ethical side, I mean, I haven't been frontline dealing with these things, so I can't offer too much of the practical advice. One thing I would talk about, I think an interesting starting point is language of do no harm. And the reason being is because that's the sort of, at the heart of a lot of medical ethics. It comes originally from the Hippocratic Oath, and that's where doctors in many contexts face these issues, and I'll leave it to the medical practitioners to talk about. But then humanitarians have also introduced this language over the last 20 years, and it started off actually from a large questioning of existing humanitarian imperatives around neutrality, around confidentiality, and all that. And so how do you preserve, I mean, a lot of times the dilemmas that come up are actually a questioning of some of the basic humanitarian principles. And then, so how do you do no harm? One caution I would give about that, and this is just to talk about some own research I've done, is that do no harm gets used everywhere by everyone now in the international community. It's often very vague. It's often not understood. Often what it does is help to flag dilemmas. And even in the humanitarian context, what it's really about originally is understood as doing proper analysis of conflict and understanding context. So I think that's a first step. Make sure you know where you're going into. Make sure people are prepared. The existing ethical frameworks, from what I understand, for medical care aren't suspended, so you still have to understand. And that's actually, I think, yesterday Steve Cornish mentioned is that the ethical and risk analysis have become so strong that it's actually hindered people's operations. And then it falls on local context. So what you come back to the dilemmas, and one thing to say, I think it's very useful language to capture the problem, but what it doesn't do is resolve the dilemmas people's faced with. And if you look at, because I did it a couple summers ago, I tracked down every reference to do no harm I could find to try to make sense of it. And what you find, there's a lot of talk about it, a lot of commitment to it. It's established best practice, a lot of good guidebooks and guidelines on how to do it. But when trying to look at how it's being applied in context, keeps coming back to the same point that the important job of trying to understand what do we do when we face the dilemmas, those questions get unanswered because they're difficult, they're uncomfortable, and you can't sort of a priori in the outset have an answer to it because everything has been mentioned is so contextualized. But that really needed work of, okay, do we sacrifice good care to give some care over more care? Do we actually put ourselves in the risk in order to save? And they're very hard questions because, again, you're back to a situation of in a sense, lawlessness, back to respect. I mean, humanitarians should be able to just get on to their work, and you're not. And so just the language are there, the tools, but what tends to get left behind is actually, okay, are we going to try to really to solve this, or at least say, maybe this, maybe that, and have some clear guidance. It gets kind of lost in the shuffle, and that's really the crucial issues.
Thank you for that, Adrian. I see, Niels, that you have you want to probably jump in hot pursuit, and then I want to ask Josephine also about these dilemmas because I think you're starting to paint a picture now of how difficult it is to make those decisions. Niels?
Just a very brief comment. I think, I mean, do no harm is it's a useful concept, both for medicals. I mean, if you get someone in, if you get a patient in with a headache and they leave as an amputee, you will have done harm. And it forces you to think of how your actions influence your environment, because if that happens, of course, you will have someone coming after you, being quite angry, right? And very often, what we fail to see as humanitarians is that good intentions ultimately aren't really enough. You can have good intentions, and that's a start. But then you also have to go and look at how your actions and what you do and what choices you do, where you operate, who you work with, what you do, down to the nitty-gritty, how that might affect how people see you. The best form of acceptance we have, I mean, in MSF, this is our experience, is to do good quality work that is recognized as valuable. And if you fail on some level, you very often end up in security situations that you are complicit in, that you have created in part yourself. So one way to look at the whole agenda for our perspective internally is what do the security situations that we face say about our own choices? I think that's potentially a good approach.
Joséphine, j'aimerais avoir votre perspective sur...
Josephine, your perspective on the ethical dilemmas, because there is a reality that you face on the field. You already gave us some examples. You told us that, yes, you should always ensure quality, the quality of care and care standards, and that those standards will vary depending on the context. Can you tell us more about how you make those choices in front of those dilemmas? Well, as the previous speakers have said, it's a very complex situation because for us, our starting principle is that we should offer quality care, but in certain situations, it's hard to do that. And the fact that it is the lack of security that is preventing us from providing quality care, within the team we'll ask ourselves, do we continue providing care that is not high quality because of the insecurity, or do we withdraw to ensure that everything is perfect before we provide care? There are times when it's pointless providing poor quality care because then we're violating our principles of providing quality care. So it's really a tough situation. And as the previous speaker said, documents are being prepared to show us how to improve our interventions. And as Adrian said, this is something that we have to fight to put an end to those conflicts because it's the population that is suffering. When you show up in the clinic, you see how many people are abandoned when the teams have to evacuate. Those people being abandoned are crying, and we who are living are also crying because we're leaving them bleeding with swords that are running, women that have to give birth. So our security chief tells us we have to leave at the very minute when, and we have to leave the next minute. But I keep wondering, how do we stop this? Yet it has to stop, because when you arrive on the field, it's terrible. Now, you're really appealing to the law, and I would like to ask Rob and Niels to talk to us about our commitment, or how do we engage the
as well as governments, to have a greater respect of the law. Maybe you can illustrate in a few sentences, both of you, the approach of MSF and ICRC, and then we'll open it up for further questions. Because I think that's a key element, too, of the awareness. It's not just awareness here in this room, it's awareness with the belligerents. So tell us a bit more about your approach.
Well, I guess it's sort of part of our ongoing work to be in contact with non-state actors, and in contemporary conflicts there are more and more of them. So it's sort of part of our daily work. We are trying to increase our own capacities internally of our staff, including our health staff, to be better at these interactions, to share best practices and learn from them, of course, adapted to the context. I should have mentioned that one of the expert workshops that we held as part of this series was precisely with a group of non-state actors. Now, that one was sort of an interesting one to organize. I won't say where it was, because you can imagine it was very low-key, but we found one state that was willing to host a sort of interesting and eclectic group of non-state actors, representatives from several continents, who spent a few days talking about healthcare and danger, these problems, and how it affected them and how it affected the populations that they claim to be interested in protecting and serving, and how it might also benefit them as parties to a conflict to have better respect for the rules. So that was a sort of innovative measure that we undertook, and it'll feed back into our practices that we'll be sharing. But going forward, we're continuing to call on non-state actors, as we do on states, to do more with this. And we think it's important to, just on the advocacy side, that states like Canada that get engaged in conflicts and political, global, military situations around the globe are mindful about their influence that they may have on non-state actors. So as in many conflicts we see around the world, there is interplay between states that are supportive of non-state actors, and we say, well, that's life, that's war. But if you're going to be doing that, then there is certainly an obligation to use the authority of any state to try and insist that non-state actors respect these minimum roles. So we see that as very important as well.
Niels, can you say a bit more about the MSF engagement with those groups? And I don't want to imply that it's only non-state actors that are committed violations. I think those violations are coming from all sides. But
yeah, that was going to be my first point. I agree completely. Very often the daily bread and butter of your security situation is based around looting and economic criminality and you know, the stuff that is not very related to international law. Now, with non-state actors, of course, that's when you run into some problems. Let's be honest, some actors don't care about international humanitarian law. It's not seen as relevant. It's seen as a tool for a specific agenda in some cases. And of course, there have been cases where international humanitarian law has been denied to non-state actors or to terrorists, etc. And so, yeah, it forces this question, well, what do you do then when you enter into negotiations where international humanitarian law isn't a very good playing card? I mean, it's got to be there. It's an important normative framework that you can use when it's useful. But then very often you end up talking about what you can provide in a very much more practical sense and trying to find commonalities of interest. And most actors will have some interest in providing healthcare, even if it is only for their own political benefit via the local population. The question is, as we dealt with in the book, I mean, do we gain access at any cost? Do we intervene at any cost? Where does the line go? And this is very much something that's written contextually, day by day, situation by situation. Yeah, I'll leave it at that.
Okay. So I think it's time to open it up again. Yes.
My name's Ian Smiley. I love this term non-state actors. What we're talking about in many cases are gangsters and thugs and murderers. It isn't that they don't know about international humanitarian law. Many of them do, but many of them don't care. And many of them are attacking humanitarian operations deliberately. They're targeting humanitarian operations. So we've got a real problem there. You want respect for the law, you have to enforce the law. If you don't enforce the law, it doesn't matter whether it's about jaywalking or housebreaking in Ottawa or international criminal law, you have to do something about it. Stigmatize the criminals, fine, but you have to get the criminals and go after them. And that's why we have an international criminal court. It's why we have the tribunals on Cambodia and Sierra Leone, Yugoslavia, Rwanda. But in many cases, the humanitarian community has fought back against these tribunals and courts. When Joseph Kony was indicted, a lot of people in the humanitarian community said, "Oh, bad idea, because it'll keep him in the bush. He won't come forward now." And many say that that's why he hasn't come forward. Is that really the truth, and does it matter? Does it really matter as long as that thug is roaming around loose in the bush? People said the same thing about the indictment of Bashir in Sudan. You can't have it both ways. I think if humanitarians want the law to be respected, then they have to give some slack to the people who are charged with enforcing the law.
Thank you, Mr. Smiley. I wonder if some of the panelists want to take that on.
Well, I'll just say it's a full-time activity of the ICRC to encourage states to implement in their national law their national legal obligations. So all of the basic rules of humanitarian law and all the serious violations, the so-called war crimes, need to be part of national measures. The ICRC view is that, of course, the tribunals are critically important. There's been, game-changing. But if we look around today, if we're realistic, there's also fatigue with international tribunals because states are somewhat tired of funding them. If we look to the future, what we need to see are states that have strong national measures, strong national laws, and that they will apply vigorously and fairly to anyone who violates them, so that whether they're a member of a government armed force or whether they're the member of an armed opposition group. Part of the Healthcare in Danger project has been indeed pushing states, calling on states to adopt better legislation to protect healthcare workers, which will then give some teeth at the national level to ensure protection in that particular context.
I think there's another question, but Adrian, briefly?
Just on ICC, because I don't want for a second to be seen as anti-ICC or anti-international criminal tribunals. I think, though, one thing I'd go back to is the point I made before is what about national level justice systems and legislation? So, and you can come at it a couple of ways. I mean, one, if you go back to the Uganda situation, and back in the time I was able to work on some of those issues, the allegations at the time is the Ugandan army, their barracks were in the middle of the camps so that the camps were shields of the armed forces, and that's when they bring the indictment to help shift some of the attention away from the Museveni's government. Hotly contested, but I was involved in a study where we actually went and asked people, how would you like prosecutions? And they said, for the Konys of the world, sure, prosecute them, but why don't we do that in Uganda instead of off in The Hague? And the very model of the ICC and the International Criminal Court is built on complementarity. So you do the prosecutions first in your national justice systems, which would especially be maybe better apt for these thugs and the criminals who one international institution for the whole world can't necessarily go after when they've made a sort of deliberate decision to go after the big guys. So I take from your point there's probably a trickle-down effect. You get the big guys, at least that's the theory. They're going to, people down the chain will get in line. But I think you have to look at it complementary way. And so it's not to say, I wouldn't hang my hat only on enforcement, for example, through the ICC. I think there's a larger question about how are you building respect for the law, and not so that it's purely an enforcement or reaction question, but I think it's the right point, though.
I see we're coming close to the end of our session, but there was a question at the back. Please, sir.
Hi. My name is Nicolas Bergeron. I'm the current president of Médecins du Monde Canada, Doctors of the World Canada. I just want to share a recent study, and it's not published yet, but it's very related to the topic today. It's, of course, if we think about the health workers being in danger, in jeopardy, we have to talk a little bit about their mental health. And so this questionnaire has been proposed to 250 humanitarian workers, expatriate, and I don't think it might be so different from the local humanitarian workers. I want to share 3 results with you. First of all, about 15% of the sample had some distress that is high enough to consider sort of a post-traumatic stress disorder. But what is explaining the risk factors related to this distress was not the direct exposure to a potential traumatic event. It was indirect exposition. And another aspect was the importance of social support, but the organizational support as well. So I'm asking maybe the panel, in your organization, what has been done to help to attenuate the impact of danger on health workers, meaning that we probably have not much show effect on the conflicts or the gangsterism, as people mentioned, but we definitely have to take care of our own people, and it may attenuate this impact. So maybe you can comment on that.
Merci, c'est une excellente question, très important. I don't know.
Thank you. Very important question.
Start?
Yes, please.
You're pointing out something that's very important. This is one of the costs of doing what we do, is that we are putting people in situations which are very difficult, and we have to be aware of our responsibility towards them. At the same time as we can't infantilize them either. I mean, we have to accept the fact that it's only the individual staff member that can evaluate the risk of what they're doing and judge whether or not this is something they want to do. This can't be done by the organization or by your HR people. It's got to be shared. We have to give psychosocial support. We have to do the support that we can. I think in MSF we can improve this further. But it forces also the other side of the argument, which is now that in our home societies we are more and more into this duty of care. What sort of legal duties do we have? What sort of social duties do we have? And we live in societies where you can't buy a coffee cup where it doesn't say, you know, caution's contents are hot, right? We're in a society where our acceptance of risk is changing. And this poses very, very interesting and very difficult questions about what we do when we send people to South Sudan or to the Congo to work in a very different context. I'll leave it at that because I don't have the full answers here. But this is something that we as an organization and the whole sector has to really think about again.
I see another question here in the front.
Thank you. John DeBoer from the United Nations University. So we've talked a lot about healthcare in context of war, conflict, civil war, if you will. We all know that more than 500,000, the majority of people actually that die of violence are in homicidal violence in situations other than war, where the application of international humanitarian law is not clear. And I know that MSF, ICRC have both undertaken studies, engaged also in contexts such as Rio, Medellin, Juarez, not the typical war situations. What have you learned from those environments? How to protect healthcare workers in those contexts that are not the classic war contexts, increasingly possibly the future of humanitarian action? Are there any solutions, lessons that we can draw from those examples?
Thank you. I think this will be our last question and answer, and then I'd just like to take 30 seconds to maybe recap on some of the possible way forward. So, Rob, is this something you'd like to address? Or?
Yeah, certainly. It's a really good question because I think something that I think Adrian was trying to draw out is that in many contexts the legal framework is not entirely clear. For the ICRC, we talk about situations where IHL doesn't apply as OSV, other situations of violence. And more for us where we're working, it's not always clear. And sometimes our legal department in Geneva will have a different view than our colleagues on the ground and than our local colleagues may have. What's clear is that in many contexts, the level of violence, particularly urban contexts, is so widespread, it has a massive humanitarian impact. So I think for us going forward, you expect the ICRC to talk about IHL, and we're not going to stop doing that. But I think our experience with healthcare in danger is that there will be lessons learned and experiences shared, we hope, which will be useful in these other contexts where many of us are working and many humanitarians are working, post-conflict situations where violence remains, where armed groups become more like criminal gangs, all of these different situations. At the same time, we're also learning in contexts like the favelas of Rio, where we've had projects for a number of years. We're worrying there and also learning from local colleagues self-coping mechanisms and other approaches of solidarity that can protect healthcare workers and their patients alike.
Joséphine, vous avez le mot de la fin.
Je voulais juste...
Josephine, one last word. I wanted to say something about team security. There's a follow-up from the various chefs de mission, and we give everyone an opportunity to express themselves. We ask people, how do you feel? Are you able to stay, or do you feel you were unable to stay considering the situation where everything is exploding around you? And so those who are able to stay can stay, but the other ones are given an opportunity to go back home. And there have to be a lot of criteria before there is mental health considered as under attack. We are asked whether we need support, and so there are organized services, because we're aware that the situations in the field can be an aggression on mental health. So if people aren't feeling well, they are entitled to tell the higher-ups that they need to go back home or that they need support from a specialist. So you're reinforcing what Niels is saying, that this is a shared responsibility between the employee and the employer. And this is a very important question that was raised by our colleague at the back. All right, thank you. I think I only have about 30 seconds left to conclude. I think there are various things. I won't leave you without any kind of hope. I think we have solutions that can be adopted to reduce attacks against health staff.
Is the need to share amongst organizations what are the coping mechanisms that are in existence on the ground, but to make sure that these are tailor-made to each context, taking into account the specific security analysis. I think that the advocacy piece is very important with governments, but also with other stakeholders, with belligerent. I take Mr. Ismaili's point that, of course, it's difficult to raise awareness of the rule of law with thugs or criminals, but despite those challenges, we need to continue to engage with belligerents on the ground. In terms of continuing our learning with organizing workshops and events, I think this is very important. I'd like to come back to Adrian's point, which is really we need to have a better understanding and tools to guide us through those ethical dilemmas. For me, I'm left with still a lot of questions around the ethical dilemmas that these situations pose. And finally, I refer you to all of the websites that are here from the various organizations so you can continue to educate yourself on this issue and follow us through next year at the International Conference of the Red Cross and the Red Crescent. So on that note, I want to thank our panelists and thank you for this session.